If my own mother were sitting across from me at the kitchen table tonight, I would take her hands, look her in the eyes, and say exactly this. There are 5 tests your doctor may still be ordering out of habit that the current evidence no longer supports for someone your age, and I need you to know that before your next appointment. My name is Dr. Elizabeth Monroe. I trained at Duke, spent years doing my internal medicine residency at Massachusetts General Hospital in Boston, and completed a fellowship in geriatric medicine at Johns Hopkins. For more than 2 decades, I have cared for adults in their 60s, 70s, and 80s. And I have watched the same pattern play out so many times that it no longer surprises me, though it still bothers me every time. A routine test flags something. That something leads to another test. That test leads to a procedure. The procedure causes a complication. The complication changes everything. The person walked in, feeling fine, and left with a new diagnosis, a new prescription, and a new fear. And sometimes, not always, but enough times to matter, none of it needed to happen. Before we go any further, drop your city or your country in the comments right now. I read every single one, and where you are watching from genuinely shapes what I cover in future videos. I want to be clear about something from the start. I am not here to tell you to distrust your doctor. Your physician, in most cases, is doing exactly what the system trained them to do. The problem is that the screening system in this country was designed for people between 45 and 65. Nobody rewrote the autopilot for age 70, 75, 80. There is no billing code for that conversation, and it rarely fits into a 15-minute appointment. That is the gap I am here to fill. What I am going to share with you is not my opinion. It is what the United States Preventive Services Task Force, the most rigorous independent panel of screening evidence in American medicine, currently recommends for adults in your age group. And in several cases, what they recommend is going to surprise you. Here's the frame that makes sense of everything I'm about to say. After 70, the goal of medicine is not to generate findings. It is to protect the quality of the life you are living right now. That is not a philosophical statement. That is the operating principle behind every major shift in screening guidelines for older adults over the last 15 years. The conventional system was built to find disease early and treat it aggressively. That approach saved millions of lives in people aged 40 to 65. But after 70, your body's relationship with time changes. Some cancers that would have harmed a 55-year-old will never bother a 78-year-old because they grow too slowly. Some procedures a 60-year-old recovers from in a week can put a frail 80-year-old in the hospital for a month. Finding more is not always helping more. After 70, finding more is sometimes causing more harm. Stay with me through all 5 of these, because number 3 carries a complication risk that most older adults have never been explicitly told about, and number 5 has been recommended against by both the American Heart Association and the USPSTF for nearly a decade. Before I go further, I need to pause for something important. If you are watching this and you have chest pain, sudden shortness of breath at rest, weakness on one side of your body, sudden vision loss in one eye, or a new lump that is growing rapidly, stop this video and call your doctor today. Everything I am discussing applies to adults who feel generally well and are going through routine checkups. If you have active symptoms, you are in a different category, and this video does not apply to your situation. When in doubt, always err on the side of calling. For those of you who feel reasonably well and are simply trying to be intelligent about your healthcare, let's talk. The first test is one that feels so routine that questioning it seems almost strange. It is the resting electrocardiogram, or EKG, and sometimes its companion, the exercise stress test, that many physicians still include as part of an annual physical. Let me tell you about a patient I will call James. James was 73, a retired electrician from the suburbs of Pittsburgh. He had never had a heart attack, had no chest pain, no breathlessness walking upstairs, no palpitations. He went in for his annual physical feeling, in his own words, better than most men my age. His doctor ordered a routine EKG. It came back with an unusual pattern, something called a left bundle branch block. Nothing that explained any symptoms because there were none, but it triggered a stress test. The stress test showed what the cardiologist described as equivocal results, meaning inconclusive. That triggered a nuclear stress test. That led to a cardiac catheterization. The catheterization found mild coronary artery narrowing, judged significant enough to warrant a stent. James left the hospital 3 days later with a stent he may or may not have needed, a 6-week recovery, a new prescription for blood thinners, and a fresh diagnosis of coronary artery disease that followed him in every medical record from that day forward. Here is what the evidence actually shows. The United States Preventive Services Task Force issued a Grade D recommendation against screening with resting or exercise EKG in asymptomatic adults at low cardiovascular risk. Grade D is not, "we're unsure." Grade D means the task force has concluded with moderate certainty that the potential harms equal or exceed the potential benefits. The American Academy of Family Physicians, the American College of Cardiology, and the American Heart Association all reached the same conclusion independently. Why? Because the EKG in a person with no symptoms has a high rate of incidental findings. And incidental findings in medicine are like a loose thread on a wool sweater. Once you pull it, the unraveling can go much further than anyone intended. The cascade from a single abnormal EKG can include stress tests, nuclear imaging, catheterization, stenting, and each step of that ladder carries its own risk of bleeding, arrhythmia, kidney injury, and fear. After 70, if you have chest pain, breathlessness, palpitations, or dizziness with exertion, an EKG is exactly the right test. It is a powerful diagnostic tool used in response to symptoms. As a routine annual screen in someone who feels well, the data says it creates more problems than it solves. Type the number 1 in the comments if you have ever had an EKG ordered at a routine physical with no symptoms prompting it. Here is where it gets more complicated, and I want to be especially careful with my language, because what I am about to say runs counter to decades of health messaging aimed at men. The PSA test, which measures prostate-specific antigen in the blood, has been one of the most widely promoted cancer screening tools in American medicine. For men in their 50s and early 60s, that conversation genuinely has nuance worth having. After 70, the calculus shifts in a way most men are never told about. Let me tell you about Walter. Walter was 71, a retired postal carrier who lived on a small farm in western Iowa. He came in for his annual visit in good health, still active, still doing his own yard work. His PSA came back at 5.8, slightly elevated for his age. His urologist recommended a biopsy. Cancer cells were found in 2 of 12 tissue samples. Low grade, slow growing. Walter was offered radiation, surgery, or active surveillance. He chose radiation, 6 weeks of treatment. When it was over, he had urinary incontinence, persistent fatigue, and erectile dysfunction that did not resolve. He told me 2 years later, "I wish I had never taken that test." The USPSTF formally recommends against routine PSA screening in men 70 and older. Their analysis found that the lack of trial evidence of benefit in this age group is compounded by a high likelihood of overdiagnosis and the immediate, tangible harms of biopsy and treatment. The false positive rate for PSA in men over 70 approaches 50%. In a room of 10 men whose test flag is elevated, 5 of them likely have no meaningful prostate cancer at all. And autopsy studies have shown for decades that a substantial proportion of men who die from entirely unrelated causes in their 70s and 80s had prostate cancer cells present in the gland and were never troubled by them in life. They died with it, not from it. The analogy I use with patients is this. Imagine a very slow-growing vine on the back wall of your house. It has been there for years. It is not damaging the structure. It is not spreading. Treating that vine by demolishing the wall is not medicine. It is reaction to a finding that did not need to be found. This is not a blanket statement for every man. Men with a strong family history of aggressive prostate cancer, men with rapidly rising PSA levels, men in excellent health with a genuinely long expected lifespan, those conversations are different and belong with your physician. But the automatic annual unquestioned PSA check after 70 is not something the evidence supports. After 70, the goal of medicine is not to generate findings. It is to protect the quality of the life you are living. This brings us to something that may be the most important chapter for people specifically in the 75 to 85 range, and it is the one where I most consistently see patients blindsided. The colonoscopy has done extraordinary work in American public health. Colorectal cancer screening between 45 and 75 saves a significant number of lives. I want that on the record before I say anything else. After 75, the USPSTF states explicitly that the net benefit of routine screening colonoscopy in all people in this age group is small. After 85, the American Cancer Society says colorectal screening should stop. Here is the mechanism, and it is something your doctor almost certainly has not had time to walk you through. As you age, the wall of the colon becomes thinner and more fragile. It is the same process you see on the outside of your body: thinner skin, easier bruising, slower healing. It happens on the inside too. A systematic review analyzing colonoscopy complications in older adults found that adverse events, including perforation, bleeding, and cardiovascular stress during sedation, occur at nearly 26 per 1,000 procedures in adults over 65, and approximately 35 per 1,000 in adults over 80. The bowel preparation itself is a separate hazard. In older adults, the overnight purge required before a colonoscopy can cause significant dehydration, electrolyte shifts, and in frail patients, a dangerous fall during a nighttime bathroom trip. Dorothy was 78, a retired librarian from a small coastal town in Maine, still sharp, still doing the Saturday crossword in pen. She came to me as a new patient with a colonoscopy already scheduled, her 5th since turning 50, all of them clean. When I reviewed her record, I saw hypertension, mild kidney impairment, and an anticoagulant for atrial fibrillation. Each of those factors meaningfully elevated her personal procedural risk. I asked if anyone had ever explained that to her. She said no one had offered that information. We talked through the alternatives together. She chose the fecal immunochemical test, a simple stool sample that requires no preparation, no sedation, no procedure, no day off, and is available at most pharmacies for less than $30. She has done it every year since. If you have never been adequately screened for colorectal cancer, the conversation around colonoscopy at 76 is different from someone who has had clean results for 3 decades. But the automatic scheduling that never stops and never asks the question, is this still right for this patient at this age, is exactly the kind of autopilot that deserves to be turned off. How old are you? Write your age in the comments below. I am not being conversational. It genuinely shapes which topics I prioritize in the coming weeks. Now I want to address something that requires particular care, because this is a test that has been wrapped in life-saving messaging for so long that questioning its value in older women can feel almost dangerous to say out loud. I'm going to say it anyway, because you deserve the honest picture. A study published in 2023 in the Annals of Internal Medicine, led by researchers at Yale School of Medicine and analyzing more than 54,000 women on Medicare, found something every woman over 74 should know. Among women aged 70 to 74 who underwent routine screening mammography, approximately 31% of breast cancers detected were tumors that would never have caused symptoms or shortened their lives. Among women aged 75 to 84, that figure rose to 47%. In women 85 and older, 54%. That is not a false positive. A false positive means the test said cancer, and there was none. Overdiagnosis is different. The cancer is real, but it is the slow-growing kind that would never have caused a problem during that person's lifetime. The challenge is that medicine currently has no reliable tool to distinguish the quiet sleeper cancer from the aggressive one at the moment of diagnosis. So the default is to treat, surgery, sometimes radiation, sometimes chemotherapy. For a woman who is 80 years old with heart disease and arthritis, that treatment course can cause more harm than the cancer itself would ever have caused. Helen was 76, a retired schoolteacher from rural Georgia. A screening mammogram found a small lesion. The biopsy confirmed cancer. Her oncologist recommended a lumpectomy followed by radiation. Helen asked me what I thought. I told her honestly what the research showed about her specific age group and the pathology of what was found. I encouraged her to have that same evidence-based conversation with her oncologist. She chose watchful monitoring. She's now 80 years old, still teaching Sunday school, still well. The USPSTF ends its routine mammography recommendation at age 74. The American Cancer Society recommends continuing for women in good health with an expected lifespan of at least 10 more years. Both positions have legitimacy. Both require an individualized conversation, not an automatic appointment scheduled year after year without asking whether it still makes sense. If this video is giving you something useful, hit the like button right now. It helps this kind of evidence-based information reach more people who need it. The fifth test is one you may have been offered at a health fair, a community wellness event, or a concierge medical screening package. It is the carotid artery duplex ultrasound, used to detect narrowing in the arteries of the neck that supply blood to the brain. It sounds like exactly what you would want to know about. And yet the USPSTF, the American Heart Association, and the American Stroke Association all formally recommend against routine screening for carotid artery stenosis in adults with no symptoms. Their 2021 recommendation, published in JAMA, concluded with moderate certainty that the harms of this screening outweigh the benefits. Here is the mechanism that makes this counterintuitive recommendation make sense. Carotid stenosis, narrowing of the neck arteries, is responsible for only a small fraction of all strokes in the United States. The majority of strokes in adults over 70 are caused by atrial fibrillation, poorly controlled blood pressure, and elevated blood sugar. None of those are detected by a carotid ultrasound, so from the beginning you are looking in the wrong location for most of the actual danger. But the real harm lives in what happens after a positive result. The treatment for significant carotid stenosis is a surgery called carotid endarterectomy, in which the plaque is physically removed from inside the artery. That surgery carries its own real risk of stroke, heart attack, and death in the perioperative window, meaning in the days surrounding the procedure. You take the procedure to prevent the stroke, and the procedure can cause the stroke. Think of it like this. You hear a strange noise in your neighborhood and call in a demolition crew to investigate. There was no fire, but the crew's arrival causes an accident that burns down the garage. That is the risk architecture of carotid screening in asymptomatic adults. Barbara was 72, a retired accountant from just outside Asheville. She paid out of pocket for a vascular screening package at a community health fair. The ultrasound showed 65% stenosis on the right side. She was referred to a vascular surgeon. She was terrified for months during the referral wait, the follow-up imaging, the specialist consultations. The surgeon ultimately recommended watchful waiting and medication adjustment. No surgery needed. But the fear, the sleepless nights, the additional scans, the specialist bills, none of that was free. The specialist bills, none of that was free. And none of it would have happened if that initial screen had never been done. Preventing stroke is one of the most important things we can do for adults over 60. The way we do that is not by hunting for plaques in the neck. It is by keeping blood pressure below 130/80, by identifying and treating atrial fibrillation, by managing blood sugar, and by walking every day. Those interventions are free. They are evidence-based, and every one of them is available to you tonight without a single test. After 70, the goal of medicine is not to generate findings. It is to protect the quality of the life you are living, and the best protection available is rarely a scan. It is usually a habit. So where does this leave you practically? It leaves you with information you can bring to your next appointment, not as confrontation, but as a participant in your own care. A good physician will welcome every one of these questions. Here is what to do before your next checkup. Step 1. Write down the last time you had each of these 5 tests and whether symptoms were present or whether it was purely routine. That list belongs in your hand before you sit down in that exam room. Step 2. Ask your doctor this exact question. Given my age and overall health, does the benefit of continuing this test outweigh the risk of what we might find and feel obligated to treat? That question is evidence-based, it is respectful, and it costs nothing. Step 3. If any of these 5 tests is being scheduled as routine and you are over 70, ask what the United States Preventive Services Task Force recommends for your age group. That information is public, it is free, and it belongs to you. Step 4. Ask about the less invasive alternative, a stool test instead of a colonoscopy, blood pressure control instead of a carotid scan. These are not compromises. In many cases, for adults over 70, they are the smarter, safer choice. Step 5. Bring someone with you. A family member, a friend, a trusted person whose job in that room is to ask the question you might forget when you are sitting across from someone in a white coat. None of these 5 steps requires a prescription, a lab, or an out-of-pocket cost. They require only that you walk into the next appointment prepared. After 70, the healthcare system will keep offering you tests. Some of them you should absolutely accept. Some of them deserve a real conversation before you say yes. The difference between the two is information, and that is exactly what I am here to give you. You did not make it to 70 or 75 or 80 by being passive about your health. You got here by paying attention, by asking questions, by advocating for yourself and the people you love. Keep doing that. Just do it armed with the most current evidence, not the most automatic habit. You deserve to age on your own terms. Leave a comment below and tell me which one of these 5 tests you plan to ask your doctor about at your next appointment. I read every single one, and your comment might be exactly what someone else watching needed to see. And if you know someone who is heading into a routine checkup this month, send them this video. It might be the most useful thing you do for them this week. I make videos like this every week because the conversation your doctor did not have time to finish deserves a place to continue. Subscribe so you do not miss the next one. Next week, I am covering one of the most commonly prescribed medications in adults over 65 and why the dosing that works at 50 may be doing something very different to your body at 75. Until then, take care of yourself and take care of someone you love.